Hello and welcome to Sureena Speaks, and today we're going to look at chapter 13 of the BNF, which is focused on the skin. So this chapter I'm going to do slightly differently. I think we'll focus more on the general sides of the chapter first, and then we'll go and look into specific skin infections, and that's where most of this video is going to focus on. Because with exam questions, a lot of the time they will either show you a picture of a skin infection or they'll give you a description of a skin infection, and you need to be able to identify what condition that is, what treatment options are available. So we'll do that, we'll focus more on that. But just looking at the skin chapter in general, there's so many different formulations that are available for the skin, and usually based on patient preference and what properties those formulations have will then determine what is prescribed to the patient. So for example, if you want something with a high water content or something for the face or the scalp, then gels are most appropriate. If you want something to cover a large area or a particularly hairy area, then lotions would be suitable. Creams are great for absorption and they're less greasy than, say, ointments. But like I said, a lot of the time it's down to patient preference and it's down to what properties each of those particular formulations can bring. So now let's focus on topical corticosteroids. So with topical corticosteroids we know are great in inflammation, so they can be used in eczema, contact dermatitis, insect stings. But once stopping a topical corticosteroid, you can get relapse. And use should be avoided on the face and on the flexures. So this part of your arm and the equivalent part of your leg should be avoided in those two areas. So now let's focus on hydrocortisone. So hydrocortisone can be bought over the counter, but only in certain conditions. Firstly, it should only be used for a patient over 10 years old. It can't be used over the counter for under 10 years old or in pregnancy. It should be used once or twice a day for a maximum of a week only, and it should not be sold for the face, the anogenital regions, broken or infected skin. Just some general notes for topical corticosteroids in general. They shouldn't be applied more than twice a day, and a lot of the time topical corticosteroids will be spoken about in terms of fingertip units. So this little section, this is a fingertip unit. It's one fingertip unit, and it's usually equivalent to around 500 milligrams of a tube of cream. And one fingertip unit is enough to spread on 2 adult hands. That's what it's the equivalent of. If you're using different preparations, then leave several minutes gap between using one from another. Now, corticosteroids can be classified based on their potency. So the 4 classifications are mild, moderate, potent, and very potent. And I know something like Proscript, when the label is made, it will actually say on there what potency that particular corticosteroid is. And even if you don't use Proscript, it's really important to get into the habit of, whenever you're dispensing a corticosteroid, a topical corticosteroid, to think to yourself, what potency is this corticosteroid? Because it is something they could potentially ask. So something of mild potency would be something like hydrocortisone. Moderate would be Umivate, so clobetasone butyrate. Potent would be like beclometasone valerate 0.1%, and very potent would be Dermavate. You can also get mild corticosteroids with an antimicrobial, such as Canesten HC, Fustin H, or even Dactocort. And Dactocort you can actually buy over the counter in a 15-gram tube if you need a product that has a product for a condition that is antifungal, that needs antifungal and inflammatory properties. Corticosteroids could actually be used in children as well. So for example, 0.5% or 1% of hydrocortisone could be used in nappy rash, 1% could be used in atopic eczema in children, but those would have to be given over prescription only. The only time we could give it over the counter is if the child is over 10 years old. Moving on to perspiration, sweating, we all sweat, but some patients have a condition called hyperhidrosis, which causes excessive sweating. And a product that can be used to treat this is aluminium chloride hexahydrate. It is available as a pea product in a 30 ml bottle, and it can come as either a liquid or as a spray. It should be used at night time, and you need to avoid contact with clothing. If this is still ineffective, then something like Botox might be the route that a patient needs to go to. Very briefly on photodamage. So I know the UK doesn't get a lot of sunshine, but we still need to be aware of sun damage and the damage it can cause to our skin. So we should be wearing our high SPF sunscreens, try and avoid excessive sun exposure, sunbeds, and for people who have had excessive sun exposure, they can end up getting dry, scaly skin, known as a condition called actinic keratosis. So what can be used to treat this is something like fluorouracil cream, but response of the treatment should be assessed after 8 weeks of using it. Could also use a treatment such as diclofenac 3% gel, which comes in the brand Solar Ease. So moving on to skin cleansers, antiseptics, desloughing agents. So an example is chlorhexidine, which comes in the form of Hibi scrub. It has antiseptic properties, which is why it makes for a good skin cleanser. You also have hydrogen peroxide. Up to 6%, it can be used to cleanse wounds, ulcers, and as a cream, it can be used for bacterial skin infections. An example of a desloughing agent is maggots. Yep, little maggots, the little creepy crawly things, because they're actually really great in wound management and they are prescribable on the NHS. And in terms of skin disfigurements, camouflages, these need to, if they are prescribed, these need to have the markings ACBS on the prescription. They are not prescribable on the NHS for post-operative scars unless it's being used as adjunctive therapy in emotional distress, where patients have a particular skin condition and it's causing them emotional distress. Only then, as an adjunctive therapy to that, can it be prescribed on the NHS, which I think is a little fun fact. You also get hyperinoid, which can be used to improve circulation. For example, in the case of bruising, thrombophlebitis, and it comes as the brand Hirudoid. Briefly on dry and scaling conditions, so we could use emollients. Now, emollients are great at hydrating the skin, making it all nice and smooth. And ideally, when you put an emollient on, you want to do so in the direction of hair growth to reduce folliculitis. And you want to, if it's a tub, spoon it out rather than dipping your fingers in, because then that can increase the risk of bacterial contamination. Now, what emollient is used depends on patient preference, their condition, the site of application, and there are so many different types of emollients out there. For example, aqueous cream, that can be used as a soap substitute for washing hands or for bathing in. You can get emollients that contain antimicrobials, for example, dermal. You get emollients that contain colloidal oatmeal, for example, Aveeno bath oil. And you get emollients that contain paraffin, for example, E45 wash. Now, a lot of emollients also contain urea, and urea helps enhance penetration. And this can be suitable, for example, in the elderly, they can use it. And examples are E45 itch relief cream. So that's the difference between normal E45 and E45 itch relief. So let's talk about skin infections. And there are so many different examples and types of skin infections. So let's start off with the antifungals. Now, if you get an antifungal infection, carry on with treatment 1 to 2 weeks after the infection is gone to prevent recurrence. You can get topical preparations, you can get systemic. Systemic would be used in cases where it's widespread or in difficult areas, for example, the scalp. You can get your imidazoles like meconazole, ketoconazole. There's also terbinafine. And let's think of ringworm as an example. So ringworm is a really classic fungal infection. And depending on where it is in the body, it's given a different name. So for example, in the scalp, it's tinea capitis. Just think you wear caps on your head, so capitis for the scalp. There's tinea corpus for the body, so your corpse body, tinea corpus is ringworm on the body. Tinea cruitis is the groin. Tinea unguium is your fingernails. And tinea pedis is your feet, like pedicures, pedis. And what is worth doing with skin infections is getting familiar with yourself with what they look like, because as I mentioned, they can show you a picture in exam and then they'll expect you to know what skin infection this is based on the picture. Typically, ringworm, especially when it's on the body, it will be a red round circle on the outside, a ring essentially, and it can be kind of yellowy on the inside, so it has a very distinct look. You can also get fungal infections in the mouth, such as oral candidiasis, and you can get it in babies and adults and children, so either miconazole gel or nystatin suspension for that. Now on to athlete's foot. So athlete's foot is tinea pedis. Typically, it's on the 4th and the 5th toe, in between the 4th and the 5th toe, that's where it affects. If it affects more than 3 toes though, patient needs to be referred. And any conditions to do with the feet, you need to ask the patient if they're diabetic, because if they are, again, you need to refer them. There's also a nail condition called onychomycosis. Who knows if I'm saying that right? And that can be caused by mold or a yeast infection. It can make the nails quite yellowy in colour. There can be the appearance of debris inside the nails, and the nails can also appear raised. Predisposing factors are, for example, age, gender. It seems to be more prevalent in males than females. Nail trauma, diabetes, and we could use something like amorphine to try and treat it. So moving on to warts and verrucas. So it's caused by the human papilloma virus, and it can appear on the hands, the feet, and the anogenital regions. So warts should only really be treated if they're painful, persistent, or unsightly. And first-line treatment, which you can buy over the counter, is salicylic acid. So this shouldn't be used in under 2-year-olds, and it can come in the form of a medicated plaster, for example, Scholl corn plasters. You can also get formaldehyde and silver nitrate. In terms of anogenital regions, you need to screen for any STIs, and it could be treated with podophyllitoxin, cryotherapy, or imiquimod. With warts, when they're on the hand or on the feet, you want to file them down. You can do so, for example, with a pumice stone. And you want to make sure that if you're using salicylic acid, for example, that you actually put it directly onto the wart, and you need to protect the skin around it so that it doesn't cause any irritation to surrounding skin. And you can do so with specially designed plasters or by putting soft paraffin there. So now on to eczema. So there's many different types of eczema. There's allergic, contact, irritant, but the most common is atopic eczema. And you can get itchy, dry, cracked skin, and it can appear on the inside and the outside of the knees, inside and outside the elbows, the neck, the scalp, so it can affect many different areas. Typically, we use emollients, corticosteroids, or even antihistamines. You can get something called lynchification, which is when you've repeatedly scratched the area. In these cases, you would need to use, again, a potent corticosteroid, or you could even resort to coal tar and ixtamimol if it's chronic eczema. If there's a bacterial infection, that can actually exacerbate eczema. So you would need to use an antibacterial for 1 week. And it should only be used for 1 week because you want to try and avoid bacterial resistance and skin sensitization. Another note for eczema is that in the case where it is very, very persistent, you might need to use drugs that affect the immune response, for example, cyclosporin. There's also oral retinoids such as alitretinoin. This can be used for hand eczema when corticosteroids have failed or corticosteroids have been unresponsive in hand eczema. Diet can also affect flare-ups. So some people find that if they eat dairy or wheat, that actually makes their eczema worse. So now on to psoriasis. So psoriasis is epidermal thickening and scaling of the skin. It can be described as red, flaky, but its majority of the time it's described as silver scales. So in an exam, if you see the term silver scales, alarm bells should be ringing that, okay, this question is regarding psoriasis. Psoriasis can also be exacerbated by other medication, for example, lithium, NSAIDs, beta blockers, even ACE inhibitors. So what can we use as treatment? So we can use emollients. For chronic plaque psoriasis, first-line treatment would be a potent topical corticosteroid, such as betamethasone 0.1% cream, and a vitamin D analogue like calcipotriol. If after 4 to 8 weeks, though, getting a lack of response is ineffective, we can resort to phototherapy with UVB. There's also a product called Dithranol. Dithranol you would leave on and then you wash it off after 5 to 60 minutes. Side effects though of this include irritation and even staining of the skin. In terms of scalp psoriasis, you want to use tar-based shampoos, and these you would either leave on for an hour or even overnight. You can use systemic treatment. This is usually for persistent or resistant psoriasis, and this includes cyclosporin, methotrexate, or even infliximab. So now moving on to acne. Acne is actually something that I suffered with as a teenager. General advice that you could give to someone with acne is to wash their face twice a day with lukewarm water and a mild soap. If they want to wear makeup, then choose water-based, non-comedogenic makeup over, say, oily-based heavy makeup. If it's mild to moderate, we can use topical. If it's moderate to severe, we'll need to use systemic. So an example of the topical products that are out there, there's benzoyl peroxide, there is erythromycin, clindamycin. With benzoyl peroxide in particular, it can cause redness and it can cause skin irritation. If there's no benefit after 2 months, then we'll need to look at an alternative. You can also get azelaic acid, again it's a topical preparation, and it's less irritating than benzoyl peroxide. In females only, if they have moderate to severe acne, we can give them cosiprindiol. This can also be used in moderate to severe hirsutism. Other systemic options are, for example, our tetracyclines. If tetracycline doesn't work, we can use doxycycline or limacycline. And if everything has failed, then one of the last resorts that we would go to is isotretinoin. So this is usually in the case when you've tried the antibacterials, you've tried the topicals, you've tried everything, nothing else has helped. With isotretinoin though, it's quite beneficial in patients over 30 or 40 years old when topical antibacterials have become ineffective or unresponsive even. And with isotretinoin, it is toxic, so it can only be prescribed by a consultant dermatologist. Now, for females in particular, it is teratogenic, so patients will really need to be advised on contraceptive advice, and females will need to be under a pregnancy prevention program. And if you've ever seen a prescription for isotretinoin, it will actually say on there, pregnancy test negative, and a pregnancy test needs to come out negative in order for them to be supplied isotretinoin. Now, usually only a maximum of up to 30 days supply can be given, and the script is only valid for 7 days. After 7 days, it's considered expired. They'll need to get a new prescription. If psychiatric changes occur whilst on isotretinoin, it needs to be stopped straight away. And looking at rosacea, it's non-comedonal, so we don't tend to have spots with rosacea, and it's described as a red butterfly shape across the face. So topically, we could use bromonidine, metronidazole, azelaic acid. Systemically, we would use tetracycline, oxytetracycline, erythromycin, or even camouflages can be used. Now let's focus on chickenpox versus shingles. So I have person A and I have person B. Now, for argument's sake, let's say person A had chickenpox a year ago, so they don't have chickenpox anymore. Person B has shingles at present. If person A walks along and interacts with person B, because they've had chickenpox already, they are not going to catch shingles from this person. Shingles isn't contagious. But now let's say we have person C. Person C has never had chickenpox before. Now when they come and interact with this person B who still has shingles, this person C is now going to get chickenpox, not shingles. So for someone who has never had chickenpox, if they interact with someone who has shingles, they will catch chickenpox from them, not shingles from them. Shingles isn't contagious. But if you've already had chickenpox and you come into contact with someone who has shingles, you are not going to catch chickenpox from them. You've already had it. The reason why someone might get shingles though is because after chickenpox, the virus might still be like chilling in the body. But then after a while, it will reactivate and it will reappear as shingles. Now, both shingles and chickenpox are caused by the varicella zoster virus. Now, in exams, especially with skin conditions, you need to learn what the keywords are. If you learn what the keywords are in relation to that skin infection, you will then know what infection it is that they're describing. So with shingles, they will typically describe it as being unilateral, so it's only affecting one side of the body. A rash, it's causing a burning sensation on one side of the body. These are all key words to describe shingles. So unilateral, burning sensation, usually it will come across the abdomen. And if a person does present with shingles, they need to be referred. And usually they're given either topical or systemic or oral acyclovir. It's a viral. It's usually always acyclovir. Now in the case of chickenpox. So in an example that they could give for a question is, a patient presents to you and they complain that they had a fever last week. Now they have a rash all over their body. On closer inspection, you can see that their rash has little vesicles, some of which are weeping. What condition does this patient have? So the reason why you will know it's chickenpox is because, again, the key words that they've used. So typically, someone who presents with chickenpox has had either a temperature or conjunctivitis a week beforehand, a week before the rash has appeared. And by the time that the vesicles have come, vesicles again is another key word, and they might even describe it as weeping vesicles. If you hear those key words, you need to be thinking, right, this is chickenpox they're talking about. It can affect the trunk of the body, the limbs, the head, the neck, just affects everywhere. And typically what you would give for chickenpox, it will go on its way on its own. For the itching, either calamine lotion or aqueous calamine. If there is still a fever present, then paracetamol, and you just need to avoid scratching if you can. So now measles and rubella. Rubella can also be called German measles, so just be aware in an exam, sometimes they might call it rubella, sometimes they might call it German measles. Both rubella and measles can be prevented by vaccine, usually given in childhood. In terms of rubella, it will be usually looks like red spots, so rubella, red. In terms of measles, they will describe it as a white dot around a red circle in the mouth, known as a Koplik spot. Any of those terms, white dot with a red circle around it, in the mouth, or the term Koplik spot, those are your key words. Those are when your alarm bell's going, right, this is measles they're talking about. You can also get symptoms of a cold with it and a rash. There's also mumps. Mumps are swelling of the glands. If a child gets it, they need to be kept at school, and you would give them an antipyretic. So give them paracetamol, ibuprofen, plenty of fluids. In terms of slapped cheek, it's a viral infection. It literally looks like the cheek's been slapped, like it's a big red mark. By the time the rash appears though, it's no longer contagious, but you'd still need to give the paracetamol, ibuprofen, fluids, and it can take about a week or so for the rash to fade. So looking at Impetigo, that's how I pronounce it. Might pronounce it in a different way, but let's go with Impetigo. So it's caused by strep or Staphylococcus aureus. Your keywords for Impetigo is that it will be described as a golden, crusting, itchy red sores around the nose and the mouth. So if they show you a picture of the nose and the mouth and they describe it in that way, golden, crusting, itchy, alarm bells, it's Impetigo. It can also be blistering in some cases. It is contagious. It is also self-limiting, so usually goes within 2 to 3 weeks, but you would give treatment if there was a risk of infection. So usually that would be flucloxacillin, erythromycin, or fusidic acid. Now on to scabies. Scabies can be caused by a parasite or a mite. It affects the web of the hands and the feet. You can get red little dots. It can also travel to the wrists, the ankles, genitals, nipples, around the nipples, and it can be described as the burrows looking like silvery lines. Now, don't mix up silvery lines with silvery scales. Silvery scales you get in psoriasis. Nice little alliteration there. Silvery scales psoriasis. Whereas with scabies, you get silvery lines. A lot of S going on here. And they're usually typically 2 to 15 millimeters in length. If it's an under 2-year-old that gets it, they would need to be referred. Now, if one member of the household gets it, everybody in the family needs to be treated. So their bed linen, their clothes, their towels, all need to be washed at a high temperature. The family would be treated with permethrin 5% cream. That's the first line treatment. If pregnant or breastfeeding though, then you'd use malathion 0.5% aqueous liquid. And you put it all over the body, absolutely everywhere. The scalp, the face, the body, everywhere. And wash it off after 8 to 12 hours. Itching can last even for 3 weeks after the infection is gone. So that's something to make your patients aware of, because they might think, I'm still getting all this itching, why isn't it going? But you need to tell them that can remain for up to 3 weeks. And what it causes the itching actually is the excrement from the little mite. So essentially their poop. Their poop is what's causing the itchiness. There's also threadworms. So threadworms can produce eggs outside the vagina, urethra, anus. So with threadworms, the person that has it, as soon as they wake up, they should have a shower straight away to try and get rid of all those eggs that have been produced. Again, it's one of those conditions where even if one person has it, the whole family needs to be treated. You treat it with anthelmintics. You can give something like mebendazole, which you can buy over the counter. Only licensed for over 2-year-olds though. It's a single dose, and only if the patient has a reinfection would they need then a second dose after 2 or 3 weeks. Now moving on to head lice. Let's not lie, I'm sure we've all experienced head lice at some point in life. And I used to hate it when you would have to have your hair brushed for what felt like hours on end and it being pulled apart and brushed. I don't even brush my hair now. But it's just not a nice experience. But there are treatment options available. 2 main ones, dimeticone, malathion. Others are available like permethrin. With malathion though, there have been some reports of resistance. Now, actually, alcoholic lotions are preferred, but you should use aqueous lotions for patients that have asthma or eczema or broken skin, because actually the alcoholic preparations can exacerbate their condition. Now, it's recommended that you leave the lotion in for at least 8 to 12 hours, wash it out, and then repeat the process in 7 days' time. In the meantime though, do wet combing. So you wet the hair, put a bit of conditioner in, or you put oil in the hair, and using a fine tooth comb, you try and brush out, as it were, all the nits and the lice, and you just try and find them with your fine tooth comb. It is very, very effective. It's recommended to do it every 4 days for a minimum of 2 weeks, and you continue doing it until no more lice are found on 3 consecutive days. Focusing on scalp and hair conditions, so dandruff is a mild form of seborrheic dermatitis. There's many different products out there that can help treat it. These include shampoos that contain antimicrobial agents, ketoconazole shampoos, tar-based shampoos, coal tar plus salicylic acid, lots of treatment options available. There's also cradle cap in infants, and this can appear as yellow, greasy scales on the scalp. It can be treated with baby shampoos. Even olive oil and coconut oil are meant to be quite effective as well. If it becomes inflamed or a rash, then we might need to give a mild steroid cream. There's also androgenetic alopecia. This can be treated with finasteride 1 milligram for 3 to 6 months, but the effects are reversed 6 to 12 months after stopping, unfortunately. Over the counter, we can get something like Regain, but which the active ingredient is minoxidil, but this doesn't help everyone, unfortunately. So now with skin conditions in particular, if a patient, for example, presents with a lump, we need to be able to identify whether or not this is cancerous. Something like squamous cell cancer can occur due to excessive exposure to the sun. And we can identify whether or not a lump is cancerous based on our ABCDE. So A, asymmetry. Does it look different on both sides? So in other words, it's not symmetrical. B, border irregularity. Does it have a funny shaped border around it? C is for colour. Does it have a uniform colour or a non-uniform colour? D is for diameter. Is it greater than 6 millimeters in size? And E is for evolving. Is it changing colour, changing shape, changing in size? So if any of those are occurring, then the patient needs to be referred straight away. So that covers most of the skin conditions that are out there. There are, of course, this isn't a limited number though, there are, of course, other skin conditions, but I've tried to condense it and focus it on the main ones. Hopefully you have a great understanding of skin conditions. I think the best way to learn this chapter though is just look at as many pictures as you can. Be familiar and identify yourself with what a wart looks like, what chickenpox looks like, what shingles looks like, and just remember those key words because that will really, really help you in the exam. And they should hopefully give off little alarm bells in your mind like, right, Koplik spot, that's measles, scaly silver scales, that's psoriasis, weeping vesicles, that's chickenpox. So learn those keywords, learn those alarm bells, and hopefully they will really, really help you in the exam. I hope you enjoyed this video. I hope you found it useful. If you did, why not give it a thumbs up, give it a like, subscribe for all the latest information and share it. And also join our Facebook page, www.facebook.com/SureenaSpeaks. And until next time, good luck with your revision and happy revisings.